Good morning, ladies and gentlemen. Let me thank Professor Malik and Professor Rishi Goyal for this wonderful opportunity. And we have been doing this course for almost 7 or 8 years now, consistently in the AOS. And every time we see a lot of outstanding ophthalmologists in this standing outside in this particular course, because always they give a very small hall for us, and that's what happens. It's okay working now, yeah. Now I'm going to take you through very fastly through the posterior capsular ring, conquering the fear of the posterior. These are my financial interests. Anybody in the audience does not have a PC rupture at all? Please raise your hand. Okay, I'm glad. I'm not the only person. So, because if you say that you don't have a PC tear, there are only two things. Only you are telling lies, or you are not doing cataract surgery at all. So early recognition combined with advances in instrumentation have made effective management. I'm going to show you only videos. Just have a look at these slides quickly. As you know, the PC tear can occur during any part of your procedure: hydrodissection, nucleus removal, cortex removal, which has been all explained. So the most important thing is there is a sudden deepening of the AC. The lens followability is lost. Lens tilt or the deepening of the posterior chamber. Look at these videos very carefully. Okay, can I have the lights off, please? Can I have the lights off and the doors locked so the people don't go out? I want to make sure people are here inside. So this is, as you can see, the sudden deepening of the posterior chamber. You are able to notice that? Right. So this is a case 1 wherein you can see here very clearly. Can you have the lights off? You can see that video better. You can see here again in this particular video. So there is a sudden deepening of the posterior chamber as well as anterior chamber, and the loss of followability. That is, the nucleus does not come to the tip as well as you want to. Despite the fact that you are having sufficient vacuum, sufficient aspiration flow rate in a peristaltic vision, but the nucleus does not come into the tip. So that should give an indication that the PC tear is underlying there. So the pupil sign has been described by Ronald. You can see here. Avoid hydrodissection in these 3 scenarios. That is a posterior polar cataract, which has been beautifully described by Dr. Paniselvam, traumatic cataract, and previous vitreoretinal surgery. If the patient has undergone already a vitrectomy and doing that, and avoid hydrodissection, or if you are doing hydrodissection, be very, very cautious. Okay, you can see here in this particular case is a posterior polar cataract. As soon as I do the chopping, you can see the whole nucleus is gone. This is another case, one of my phaco trainees, you can see a brown cataract, and my assistant puts a very heavy, dense viscoelastic into the anterior on the cornea and pushes the nucleus into. I'm just kidding, but this can also happen. What I'm trying to say is, if you have a very small rhexis and a huge nucleus, you can have a hydrorupture like what you have. But don't lose your heart, because these are patients, see, wherein you can even manage and get them very good post-operative visual acuity. This is a small PC tear. What you can do is you can convert that into a small posterior capsular rhexis. As you can see here.
Put on the light. He's doing it, boss.
Lights off, please. Yeah. You can see that posterior capsular rhexis. You can see that. And including the plaque also. So the posterior capsular rhexis has got better strength. If you have a small PC tear, convert that into a posterior capsular rhexis. And if the PC tear is little large, don't use coaxial irrigation aspiration. Come out and use bimanual, because coaxial, what will happen is it will hydrate the vitreous, and more and more vitreous will start coming into the anterior chamber, and whatever PC tear is, the little small tear will become a huge tear. So that is what you should not do. So this is one of my phaco trainees. You can see here 2007. You can see the date as well. You can see the PC tear. And there is also a small nucleus bit. He became jittery, just like all of us do, because we'll be operating on a doctor or a VIP patient. See what he did? He tried to catch the posterior end of the cortical fiber and pulled out. Do not pull out. That is very, very important. Do not pull out. When you see a PC tear, keep your calm. Introduce viscoelastic, like I am going to show you in the next video. So these are the 4 things you have to see. Avoid removal of the instruments, introduce viscoelastic, come to position 1 on the foot switch, lower the bottle height, remove the phaco handpiece very slowly and then relax, because your adrenaline is flowing is very, very important. You can see here, this was operating on a former union minister, okay, way back in 2000. You can see a very hard brown cataract. These union ministers all commit sins. So you can see here the posterior capsule tear is there, but I introduced during the last piece of the nucleus removal, I was using a lower end phaco machine. You can see the surge, because of the surge the posterior capsule tear, but I introduced viscoat through the side port. I didn't lose my I didn't lose my calm. That is very important. Introduce viscoat, stabilize the anterior chamber, come out of the eye very slowly. Then you assess the extent of the PC tear. Then you create a right side port and go through a bimanual cortical aspiration and do a bimanual anterior vitrectomy if there is a vitreous in the anterior chamber. At that time, the tricot was not available to us. Again, a case 5, you can see here again, a PC tear in a posterior polar cataract, a huge PC tear. So what I did was, because the nucleus was a little soft, I introduced viscoelastic through the side port and came out slowly. Stabilize. Introduce viscoelastic through the side port. Whatever viscoelastic is available with you, not necessarily viscoat or anything, whatever viscoelastic, even HPMC or whatever is available with you, introduce and then come out slowly of the eye. There's another patient, the traumatic cataract, can see here. And as I made a trench, I did a capsulorhexis. As I made a trench, you can see that I made a burr hole in the posterior capsule. Can you see the burr hole there? Can you see the hole there? Yeah, can you see the burr hole there? And this is the burr hole, is the posterior capsule tear. Because the cataract was a little soft, I was able to proceed, but I used a bimanual technique again. Here, you can see here in case 7, it's important that you use tricot, preservative free tricot is available in the form of orocot is available, or even I think many companies are making it now. Make sure that you put that in the anterior chamber in the beginning, not after you do a vitrectomy. After you do some vitrectomy, you put the tricot, the whole tricot will go into the vitreous cavity, and the post-operatively the patient will have secondary glaucoma as well. So you don't want to have that. You can see a bimanual vitrectomy, use a posterior vitrector. You can see that on the right side port. Again, you can see here, in this posterior polar cataract, I am using tricot in the anterior chamber. And this is again a bimanual vitrectomy. And once you do the vitrectomy, remove the remove the cortex, the bimanual, then choose the type of the lens, correct quality of the lens, or the type suitable IOL. Very, very important. If it's a bag is there, then put the lens in the bag, or put the lens in the sulcus if the posterior capsule has been lost. Assess the capsular integrity, or you can even put a glued IOL or a scleral fixation IOL or anterior chamber IOL or iris fixation, retro iris fixation, or whatever you are comfortable. So if you have a PC tear, if you follow all those protocols, you can have a good night's sleep and the patient will not trouble you. Otherwise, the patient will take the hell out of you. You will get into depression like this and you will become a drunkard. Thank you very much, and follow this APSRS meeting in November. Thank you very much for the wonderful opportunity.